Well, welcome everyone. So this is the first session of the self-compassion workshop. Um, I kind of redid things a little bit and put some of the boring stuff first, so we could get that out of the way. Um, so what we're going to be talking about tonight is a little bit of an introduction. Then we'll go into the science of self-compassion because if you don't get the science and the physiology, then as we get further along into some of the more advanced stuff, it comes across as different or maybe airy fairy or woo woo. But having some of this science and physiology understanding at the beginning, I think, gives you an idea. It kind of grounds everything in what we understand, sort of in our physically based kind of world. Um, we'll talk a little bit about what this workshop is not: physiology of self compassion. We'll talk about emotions, beliefs, and thoughts, and then eventually getting into the awareness leading to self compassion. So it starts with awareness and then leads to the self compassion. But tonight it's going to be about the science and physiology of self compassion and a little bit of introduction about where this workshop all came from. So a lot of this is my personal journey, but in addition to that, it's a journey that I'll talk about that started with what seemed to be lacking in Western medicine, in allopathic medicine. Um, the the concept of the workshop has really been probably around since um, around 2006 is when I first started teaching this. So let's say about 10 years. Um, the concept was the same, but the presentation has really evolved over those 10 years. And I think it comes across um, in a better way. I don't even know if better is the right word because it's not better for everyone. But at least it's easier to comprehend. But I'll talk a lot about sort of the genesis of the workshop, and then a lot of it again will come. Hear a lot of my personal story as well. So start with the science, mostly because again, we're this is where we live in our world, right? We're physically based, very scientific. Science is nice because you can look at numbers, you can measure the numbers, you can see what happens when you treat the numbers. So you might take blood pressure. The blood pressure's high. We know people don't do well. We have ways of bringing the blood pressure down, and we can measure that, and then we can measure how people do when you bring the blood pressure down, and see what kind of side effects they get from medicine, things like that. So it's nice. However, having said that, I think that psychological sort of issues like self compassion and such don't really lend themselves easily to science, right? They're difficult to study. Uh, the, um, the the studies that are done, they're challenging to design, um, and I think some of the concepts are difficult concepts to define as well. So compassion, I've been using the term self-compassion for the better part of 10, 11 years. It really started sort of before I started using the term before the self-compassion movement really took hold. Um, and I've kind of switched and started really uh, using the term self acceptance more than self compassion. I like the term better. Again, compassion gets a little bit difficult to define. It means different things to different people. Um, um, things like feeling sorry for someone or for yourself is what a lot of people in our country sort of understand it to be, or that's what it means to them. Um, but self acceptance, I think, is easier to define. So I use the term synonymously, but I will probably try to use the term self acceptance more. So, a lot of research now, about 10,000 articles have been written on self compassion. Krista Neff was the first to sort of measure it. I think that study came out in 2003. And research has shown both psychological and physical health benefits associated with self compassion. Um, if you want a bibliography, you can go to Kristen Neff's site, which is selfcompassion.com or selfcompassion.org. We'll get you to the same place. And she's got a bibliography of all the studies. She says they're all the studies, but then she also says there's 10,000 articles. But it, when I looked at it at the list, it didn't seem like 10,000 were there. But anyway, it's very comprehensive. And if you're looking for some of this literature that we're talking about, or literature in general, um, that's the place to look. You don't have to do a literature search or whatever. So there's a lot of cultural misconceptions about self-compassion, right? So we are a tough society, right? We're go-getters. We believe to be successful, you have to be, aggressive, hardworking, and such. And we teach as a society we're tough on ourselves, right? We have to have goals. We have to be motivated. We have to, do all the time. The harder we work, the more successful we will be. At least um, that's what's taught, or and I think well, we'll talk a lot about what that ultimately means. But when you talk about self compassion, there's misconceptions. A lot of people will equate it to self pity, indulgence, making excuses to kind of to avoid responsibilities, being unmotivated or wimpy. That's my favorite one. Being selfish or egotistical and narcissistic. And it turns out when you look at the studies, none of these, I call them misconceptions, because none of these turns out to really stand up to science. In other words, science has shown that this is not the case. So some of the benefits, the studies are very consistent. Self-compassion's linked basically to reductions in anxiety, depression, stress, shame, suicidal tendencies, maladaptive perfectionism. I love that one. Um, and and many other things. But these are, these, as you know, in our society, these are huge. Depression is essentially epidemic, right? We all seem to have a Prozac deficiency in our society, and self compassion again is something that I think at this point, with the literature that exists, is very underutilized in Western medicine. Research also shows a lot of other health benefits like increased motivation. So it actually doesn't decrease motivation, but actually increases motivation, boosts happiness, um, improves body image, enhances self worth, fosters resilience to adversity, and reduces psychological distress. These are great things, right? If we had a pill that did all these things, all of us would be on it, right? Meanwhile, there's very little teaching about self compassion. But you can also see that these are very difficult things to study or to measure. Boosting happiness. You got to have happiness ratings or scales, right? And happiness to me is kind of a momentary event. And so you won't hear me talk about happiness very often. I like to think of it in terms of peace. So I talk about misery and peace. For me, emotions, I've never been very good at identifying my emotions, and that was always a challenge. And so, in the end, I've made it very simple, and basically, it's just do you feel good or bad? Those are the only two emotions. You don't have to identify them. You don't have to rank them. It doesn't matter whether you're, in full rage or you're a little peeved, and everything in between. The scale doesn't really matter. If you're feeling negative, we'll talk about what that means, and when you're feeling positive. So the negative, sort of leads to kind of miserable kind of feelings, and uh, and the positive is more of what I refer to as peace, or being peaceful. Um, Self-compassion has also been linked to increases in life satisfaction, happiness, gratitude, self-confidence, and optimism. Again, um, these are all wonderful things, yet we don't talk much or think about much or really emphasize the importance of self-compassion. So there's a lot of just great stuff out there. I don't want to really go into too many of the individual articles. But there's a couple that I would like to highlight. Excuse me. Just to kind of show what the literature looks like out there. So if you look at the Journal of Research and Personality from 2007, again, self-compassion was linked to happiness, optimism, wisdom, personal initiative, and curiosity. Now, again, these some of these things, as you can see, how do you measure wisdom? So they come up with these scales and ways to do that. But I think the science is difficult. From my standpoint, I don't really need science for me to tell me that self-compassion is useful or helpful or good, right? I mean, there are some things that are really intuitively obvious. And this is, for me, this is one of them. The other one is gratitude, right? We've got now lots of studies showing the benefits of gratitude. I mean, we need studies to show that gratitude's a good thing. I mean, really? But again, I'm not knocking it. I just think the studies are hard to do, but I'm glad someone did them. The important thing um, about the self compassion is that not so much that it is, that people who practice self-compassion, it's beneficial or they do better or they're more at peace or happier, but that it can be learned. I think that's important. The question is, how do you learn it, right? And we'll talk a lot about that. One of the issues, and that this course is, and I should have said this in the introduction, but as I've talked about self compassion in this workshop and this content for 10 years, one thing that I noticed, um, and I didn't notice this early on because I used the same term that is used in the self compassion movement. But what I really came to understand or find out was that what we're going to talk about here is very different from a lot of the self compassion material you'll read out there. So Kristen Neff stuff and Chris Germer and Paul Gilbert and many others. They've done all the science, they've studied it, they've come up with techniques that scientifically have been shown to improve self compassion, but they didn't work for me. They weren't, I didn't find them helpful. I didn't find them motivating. And so, that's part of why I had to develop my own thing, was because um, this stuff that we'll talk about, these other techniques, just weren't effective. Now, having said that, that doesn't mean they're not effective for other people. Nothing's going to be 100% for everyone. And if those, I encourage you to look at that stuff and see what rings true for you, and use that. And what is not useful for you or doesn't fit right or feel right, then let that go. And anything, same with what I say, anything that feels good and feels right, and helps you, by all means, use it. But if there's something, and even in what I say, that doesn't feel right or doesn't feel good, then feel free to toss that aside. But ultimately, there's a lot of techniques out there, and you have to find what works for you. So this University of California study from 2011 showed that students who spent more time studying for a difficult test following an initial failure were more motivated to recover from that failure. They also reported greater motivation to change their weaknesses. And you'll see this in another study as well. Body image, that's huge in our society today, right? And so there's actually a journal called Body Image. So something's an issue in our society when you have a whole journal dedicated to that one subject. So there's a journal called Body Image, and it found that People who practice self compassion experience less preoccupation with their appearance, had fewer concerns about their weight, and had greater appreciation toward their bodies. So, again, very important stuff. Other studies have shown that there's more motivation uh, to then change that. Self compassion fosters resilience to adversity. So, in this study from 2011 in Psychological Science, showed that higher levels of self compassion are related to improved emotional recovery following marital separation and divorce. A common issue in our society. Again, very helpful. People get stressed during divorce, during separation. What do? We prescribe anxiolytics, usually in the form of benzodiazepines, and they seem to be depressed, and so we use a lot of antidepressants. Now you'll hear me sort of knock medicines a lot, but realize I have no issues and problems with medications. I mean, that's how I was trained, that's where I come from. And I don't have there's no problem using antidepressants, and we'll talk about this some more. However, um, uh, the fact that we know that self compassion is also helpful, then I wouldn't say that you have to use it instead of medication. You may try it, but it certainly can be used in addition to it. There aren't any side effects to it, especially when you add it to antidepressants and such. It reduces self-compassion reduces psychological distress. So higher levels of self-compassion are linked to decreased mental health problems. Mental health issues in our society, again, are huge. In this study from the Clinical Psychology Review in 2012, found that self-compassion decreased psychological distress, such as anxiety and depression, and it reduces the harmful effects of stress. So again, a lot of great stuff. So that's pretty much most of the science that I want to talk about. I just wanted to get through that. Mostly want you to know that what it shows in general, and that the science is there. And if you want to go read more about it and look into specifics, again, Kristen Neff's website at selfcompassion.org or selfcompassion.com is a very useful site. So moving on to strategies to achieve self compassion, or how do we develop or use self compassion? So, these are some of my favorites that you'll see on the internet, in articles and journals and what have you, right? So, be your own best friend, develop beliefs that work for you, know that you are inherently worthy. These are strategies, by the way, that I should say that don't work for me. Okay. But they sound nice. When you read this and you read that you should know that you're inherently worthy, it sounds nice. Now go do it, and good luck with that. It didn't work for me. I couldn't, anything and everything that I tried wasn't very helpful in helping me know that I was inherently worthy, right? Do not project your needs onto others. Give yourself the gift of happiness and peace of mind. Really? Just go ahead and do that. It's not that easy, right? Like they tell you this is what you should do, but they don't tell you how to do this. So this is a technique to help this workshop, ways to do that. Okay, ways that have worked for me, ways that worked for hundreds of my friends and patients, um, but not for everyone. So again, try it, see what works for you, see if it makes sense, see if it rings true, and if it does, by all means, use it. Um, Take great care of yourself. What does that mean? Right? I remember, when I had my integrative cardiology practice, we had massage therapy in the office, and so I decided at one point I was pretty stressed. Things were pretty stressful, and and we had massage therapists. I decided I was going to get a massage once a week at lunchtime. That seemed like a good thing, right? So, get some of all that stress out in the middle of the day, and help me for the afternoon. And so I ended up doing that, I think, twice. And the reason was, I did it and everything was nice and fine. And, I felt great and I was done. We had showers in the office, took a shower, and I was ready to go in the afternoon. And within, I don't know, I'll be generous and say within an hour, maybe an hour and a half, I was back to, tension. I carried tension mostly in my shoulders and neck, that my neck and stuff was tense again. I had a headache again. And basically all the effects of the massage, were gone. And, because it didn't get to the root of the issue, right? So I thought I was doing something to take care of myself. But what, again, and we'll talk a lot about this, but you can take anything like, getting a massage and turn it around depending on how you perceive it. So a lot of what I was perceiving after was like, oh, I can't believe I spent, my lunchtime doing that. I have so much to do. I'm so behind. I should have been dictating my charts, or I should have been reading echoes, or I should have been doing, all this other stuff. Now I'm going to have to do that tonight after I'm done seeing patients, and I'll get home even later, and I will go get to exercise and yada yada yada. Right. So so it's not the act of doing whatever it is that you're going to do. It's really the perception. And again, we're going to get that's what we're going to spend most of our time talking about over the next several webinars. Other thing I should say about these webinars, I forgot to say, is how many will there be depends on how things go. I can present this material in probably 2 or 3 hours. Um, the content of it, but in all honesty, it truly is, um, it truly is meaningless. It's, again, it sounds like this stuff. It'll sound really nice, and you'll say, "Oh yeah, that makes sense. Yes, yes, yes." But the real important part comes in helping you apply it to your situation, to your life, to your individual scenarios. And the nice thing about the group settings, so I've done this in many types of group settings, all the way from half day, meetings with 50 to 100 people, to full day meetings, to small group, several day meetings, usually like 10 or 12 people. They're all advantages and disadvantages to all of those. But when people participate and you get to hear how this applies to all these individual scenarios, then you can start to put it together and see, one, that it's universally applicable, and then how it might apply to your situations, to all of your situations. But anyway, all of these things, tune into your authentic self, eliminate negative reactions. Are you kidding me? Eliminate negative reactions? Really? Is that even possible? I know even enlightened monks that have negative reactions, or what I perceive as negative reactions. Appreciate what you have. That one's kind of easy. We can do that. We'll spend some time on gratitude. Enjoy the present moment. Pass your compassion on to others. I mean, these are all, again, for me, these don't work. This is what this workshop is not. It's not these sort of almost platitudes that we put out there that sound nice, but don't help you, and don't tell you how to do it. So, what other ways to maybe achieve some other strategies to achieve self compassion? So, you see this kind of stuff on the internet all the time, right? You see these little signs and little posters and such. You are good enough. Well, if most of us see this, most of us don't really inherently believe that we are good enough. And so this is sort of a lie, right? And if you say it to yourself enough times, fake it till you'll make it, then you'll start to believe it. That never worked for me. It might work for someone else, and if it does, that's great, because it's a lot easier than what I went through. But this kind of stuff, just reading this or looking at this or putting this on my wall, never really helped. Something like this. I love me, right? Um, mm, if you don't believe it, can you lie to yourself? Can you really fake it till you make it? If it works for you, great, do it. You could do this. You could take, a self acceptance sort of saying quote, and tattoo it on your flank like this lady did. This came off the internet. It's a little bit hard to read, so I will uh, translate it here for you or put it where you can read it. So, what it says is the only acceptance we truly need is self acceptance. For once we have gained that, the rest should come, and that which does not come will not matter. It's really nice. It's true, I think. But how do you go ahead and just do that and just start accepting yourself because you read this? The other problem with this is who's it written for, right? Is it written for her? Is it written for other people? Certain, because if it's written for her, it doesn't work too well because it should be written upside down. 'Cause most of us can't see our flanks, right? And if we could and we look down, it would be upside down. If she tried to look at it in the mirror, then it should be backwards so she could read it in the mirror. So anyway, who's it for? Is it, I guess it's for other people to read, or for her boyfriend maybe. Um, but um, apparently this is fairly common because also on the internet, I found this other woman who put this saying this one's a little bit easier to read, but if you can't read it, what it says is today you are you that is truer than true. There is no one alive that is youer than you, which of course is Dr. Seuss, right? And you can tell she just had this done because she's still all red. And so, again, very nice, but who's it for? And truly, this doesn't, for me, reading it is nice, but it doesn't. How do I apply this? What do I do with it? It doesn't do much. Okay. All right. So that's all the stuff that this workshop is not. So now we'll try to get in a little bit to the basis of this workshop, and some of the physiology and what happens when we are self-critical. So, what happens when we're in the self-critical mode? What we're essentially doing is we're attacking the self, right? When you attack the self, this will then activate the body's threat defense system, right? The flight or fight response. This is a system that has been around forever, right? A long, long time, and is a very useful system, right? Because when you're being chased by that saber-toothed tiger or that lion on the Serengeti, then your body will be able to respond, right? You will flee. You'll be ready to flee or fight or freeze. And so it's a very useful system. When the body's threat defense system gets activated, this activates the sympathetic nervous system. So, what does the sympathetic nervous system do? Well, that leads to the secretion of hormones such as adrenaline, noradrenaline, otherwise known as epinephrine and norepinephrine, dopamine, cortisol. And these are all very useful when you're being chased by the lion, right? Because the adrenaline, noradrenaline, dopamine will constrict your blood vessels so that the blood pressure goes up. That way, you can get more blood to your brain and more blood to your muscles. That's a good thing, right? It will also increase your blood sugar because you're going to need more energy to be able to run or to fight. Cortisol also raises your blood sugar, it raises your cholesterol, even. So, in the short term, while you're being chased, these are all really, really good things. Okay. The problem in our society, of course, is that there aren't any saber-toothed tigers. We're not on the Serengeti. We're not being chased by lions every day, but we react as though we are, right? Because we're under stress. And what happens is that the perception of making a mistake, right? The perception of failure activates the sympathetic nervous system basically to the degree that being chased by the lion does. Okay. So we react as if our lives are being threatened. And so since we perceive ourselves as failures or making mistakes all the time, chronically, probably on a day, every day, probably multiple times a day basis, then what happens is our baseline levels, our hormones are always elevated so that our blood pressure's up, our sugar's up, our cholesterol's up, and all this kind of stuff. Okay. The key here is that this is a perception of failure and perception to choice. And that's where we're going to again spend most of our time. That all of this stuff that we're talking about is a choice. And the choice is important. It's not automatic, it's not habitual. It is habitual, but it's not automatic. You do have a choice of how you respond. So, where did this program come from? Well, um, it turns out that it was really the last day of medical school for me. And fortunately, it was the last day and not like in the middle because I'm not sure what would have happened if I would have ever finished. But it actually started 2 days before the last day when a nice 35-year-old lady came in with several days of vomiting and dry heaves and nausea. So she came in. She looked terrible. She was dehydrated. She felt awful. She was still, dry heaving and such. And so we didn't know what was going on. So this is 1986. So we put her in the hospital and started an IV, hydrated her up, and we got a abdominal ultrasound and to look for things like gallstones and pancreatitis and all that. And then we got an upper GI and to look for ulcers and such. So we went in the next day. She looked a little bit better. She was hydrated up some. She wasn't really hungry, but not didn't have all those dry heaves. And ultrasound looked normal, and the upper GI was normal. So we went ahead and ordered a CT scan, and that was done that day. And then we went in Friday morning, though it was my last day of school, and the CT scan. We looked at the results, and it was normal. So that was fine. So I was doing a family practice rotation. It was an outpatient family practice rotation, and I was with the family practitioner, and he said, "Well, why don't you go see her and discharge her, and I'm going to go back to the office, and then when you're done, meet me back at the office." So I said, "Okay, fine." So I started heading down the hall, and I realized that I was going to have to discharge her, and I was going to have to write down a discharge diagnosis. So the first thing I turned around and yelled down the hall. I said, what do I put for the discharge diagnosis? And he stopped. And he went, oh, hmm. Well, I'll put, viral gastroenteritis. I said, okay. So he left. I started going to the room. And the first thing I learned that day was that in Western medicine, if we have absolutely no clue, no idea what's going on, we always blame a virus. Right. Um, so so I got to the room and I sat down and she was looking a little bit better and I started to write out some prescriptions for nausea and fill out her discharge papers and such. And as I was sitting down writing these things out, I made some corny kind of small talk and said something like, well, we'll get you out of here and get you home so you can get some real rest because you can't rest in the hospital, right? And she said, oh, I wish. And I said, you wish? What do you mean you wish? She said, I wish I could go home and get some rest. I said, well, why can't you? And she says, well, in the last 3 months, my husband left me, my house burned down, and my dog died. And I fortunately was sitting down because at that point my head started spinning because it became quite obvious to me at that moment why she had all this nausea and vomiting. So that was the first awareness. The second awareness was I just finished 4 years of medical school and I hadn't learned one single thing about this entity, whatever it was. I hadn't learned about it. It was never brought up. It was never discussed. And I knew that I had a whole medical school library at my disposal, and I wasn't even sure that I could go and find anything written about this, and I wasn't sure where to look, to be honest with you. What was this? Yet it seemed intuitively obvious to me that what was going on. And it also seemed obvious that if I went outside and polled the first 20 people that came by, lay people, non physicians, non clinical people, or even nurses for that matter, it would be obvious to them also why she was throwing up. And the other thing was that in the history and physical, which includes a review of system and a family history and a social history and such, you know, that none of that really came out because who had time to, the talk about that? Even back in 1986, when we weren't nearly as pressured as we are today, seeing patients and in a short order and things like that. So that sort of weighed heavy on my mind. And fortunately, it was the last day, and then I, graduated, and then I was started my training, and I had to move up to Cleveland, um, and I went to the Cleveland Clinic, and this stayed in the back of my head through, but I got very busy, but it was always there. What is this about? And trying to sort that out and figure that out. Um, Fast forward about, I don't know, 15 or 20 years, maybe not that much, but um, and I saw a patient. I had a patient I'd been seeing for a while, and she had had chronic psoriasis. It was generally under reasonable control, but it was a problem. She had high blood pressure and high cholesterol. She was diabetic, and anyway, she came in one day, and I went and got her in the waiting room there and the lobby, and I brought her back. And as I brought her back, I looked at her, and her psoriasis looked worse than ever, worse than I'd ever seen it. And my comment to her was, "Man, you must be under a lot of stress. What's going on?" She said, "You haven't even like asked me any questions yet. What makes you think I'm under stress?" And I said, "Well, look at your psoriasis. I've never seen it this bad. You look like a lobster, man. It's like you're so red." And she said, "Well, what does that have to do with stress?" And I said, "Are you kidding me?" I said, "You've been dealing with psoriasis for decades, and you've never noticed that when you're under stress, that it gets worse?" And she said, "No, I've never noticed that. And no one's ever told me that. No doctor's ever told me that." I said, "Huh. It's not something we talk about, right? It's not something we emphasize, even though we sort of know about it." Interesting that when I saw a type 1 diabetic patient, guy had diabetes for about 40 years. He was about 50, and he had had it since he was like 10. Maybe it's 48. He had it since he was 8 or something like that. But I know it was about 40 years. And he had no signs of end organ damage, right? So he had nothing, his prealbumin and he had no diabetic retinopathy and uh, uh, no signs of kidney damage. His feet were fine. He had bounding pulses, no signs of any organs being damaged by the diabetes. And this guy he was an engineer, and he was compulsive, absolutely compulsive about his sugars. So he had an insulin pump, and he checked his sugars literally 12 to 15 times a day. And this guy could tell you, to the gram, how many ounces of carbohydrate or grams of carbohydrate were on his plate, how much protein was on his plate. He knew how much insulin he would have to bolus himself with based on what he was eating. He knew he was a runner. He liked to run, and he knew that when he ran, he could turn his insulin pump off because he didn't need any insulin. Anyway, this guy had it down pat. He knew what was going to affect his sugar and how and such. So so I had this opportunity because this guy was so compulsive about his sugar. I said to him, "So what raises your sugar the most?" And without hesitation, he said, "Stress." I, I was like, my head started spinning again because that's not what I intended to ask in the question, right? I said, what raises your sugar the most? But what I was intending to mean was what food raises your sugar the most. But fortunately, I didn't ask it that way. I was more open ended, and I said, "What raises your sugar the most?" And he said, "Stress." And no one had ever, you know, talked about stress back in these days, at least, about stress and blood sugar control and how much that plays a role. It was always about how much carbohydrate you eat, how much sugar, and fat slows it down, and protein, all this stuff, but nothing in there about stress. So that was fascinating. So then, of course, I said to him, well, "Okay, that's interesting, but what food raises it the most?" And you probably will never guess it, but he said tomatoes. And I said, "Tomato?" Okay, that wasn't expecting that either. So I learned two very interesting things that day. So fast forward about another 5 or 10 years, because these patients are hard to come by. That is long-standing diabetics that don't have any end organ damage. So another lady who had also had diabetes for about 40 years. She wasn't as old, but she developed diabetes when she was young, 3 or 4 years old. And again, she was compulsive. She had an insulin pump. She checked her sugars 12, 15 times a day. She knew how much, carbohydrate was on her plate, how much protein and such. She knew how much insulin she needed for how much she was eating. She was not a runner, by the way. She was active, but certainly wasn't an exercising type. But nonetheless, she knew her body and her sugar better than the average, way better than the average diabetic. So of course, I made sure that I was going to ask the question the exact same way. So I said to her, "What raises your sugar the most?" And without hesitation, she said, "Stress." And she gave me an example. It was holiday time. It was a couple of weeks before the holidays, and she was going to visit her mom yesterday or the day before, something. And she talked about how stressful it is seeing her mom, especially during the holidays, and how her sugar had gone up to like 300, and she knew it was, and she was bolused herself some more, and it was still high, and yada yada. And so then I said, "Well, what food raises your sugar the most?" And she said, "Tomatoes." So for what that's worth. So and tomatoes have a ton of sugar in them. They really do, which is why they burn. And when you make sauce, you have to be really careful and such. But again, those are not things that neither that we talk about much. We certainly don't talk about stress that much, and I'm not sure that we talk about tomatoes raising sugar more than anything else. So this really started this search for me, this search for, you know, how do emotions play into this whole health, physical body health system of ours. So I gave this talk at Wake Forest about, I think it was 2009 or so. And it was at their alternative medicine sort of grand rounds that they have conference. They had a weekly conference, and I put this slide, thoughts leading to illness. And now this was kind of a mixed group. There were allopathic, physicians, MDs, Western trained physicians. There were Oriental medicine physicians. There were naturopathic physicians. There were acupuncturists. There were counselors, therapists, psychologists, psychiatrists, um, massage therapists. Sort of, it's a very diverse group, but I knew the MDs, and I put this up, and as I put it up, I kind of paused a little bit and I watched the MDs because I could see them start to fidget a little bit and start to look at their watch and remember that they needed to be somewhere else right now. and I was seeing if anyone was going to leave, but before they left, I said, when I put this up, you makes you feel somewhat uncomfortable and you don't really know what it means. I said, but give me a few minutes here and let me fill in the middle. So let me fill in the middle. So let's take something common like hypertension, high blood pressure. Okay. Pharmaceutical companies do a lot of research showing that if that high blood pressure is bad, we know that, and that if you take their medicine and bring the blood pressure down, that you do better. Okay. However, they don't talk about, well, what caused the high blood pressure to begin with, because I don't want to say that they don't really want you to know, but certainly um, it's better for them if you just take their medicine every day and buy it every month for the rest of your life, right? Well, what's causing the high blood pressure is some kind of biochemical process that's going on, right? Well, biochemical processes don't just happen, right? Something causes them. And what causes them? Well, the secretion of chemicals, right, that then react, that cause a biochemical process that leads to, in this case, we're talking about high blood pressure, right? And what are these chemicals? These are hormones and neurotransmitters. Things like we talked about adrenaline, noradrenaline, or epinephrine, norepinephrine, cortisol, dopamine, what have you. There's thousands and thousands of them. So back um, in the early '90s, when I was at maybe the height of my misery, um, and uh, and I saw a counselor, and she said, "Well, you're depressed, and you need to take this medication." And I don't remember what it was. But it was probably an SSRI, and and I said, "Well, I'm not really into taking medicines. I'd like to, try to avoid those." And she says, "Well, you can, but it's really important that you take the medicine because what you have is a chemical imbalance in your brain that's causing this depression." So I said, "Well, I don't have, um, I don't doubt that. I don't have. I'm not going to tell you that I don't, and I agree with you. I may well have a chemical imbalance causing my depression, but how did it get there?" Well, there wasn't any talk about that, right? And I said, "Well, the medicine might improve it. That's nice, but then what?" Right? Because if I don't figure out how it got there, then at some point that medicine may stop working or may not be continually effective. So this is like what I like to say, this is where Western medicine starts, right? So we understand the hormones and the neurotransmitters, right? If you look at whatever it is, whether it's lupus or rheumatoid arthritis or what have you, we can tell you, all of the reactions and all of the hormones and neurotransmitters that are in, let's say, in the joint space, that are your immune system attacking your synovial membranes, and we understand all that, and we can tell you that, and then we can develop chemicals to stop that process or to slow it down, attenuate it to a degree, right? But but no one ever talks about why you're attacking yourself to begin with. Why are you making, the immune system is incredibly um, sophisticated system that's set up to really um, you know monitor, what's going on in the body, and it's supposed to be able to recognize the self and the non-self, right? So why would it go, awry and start all of a sudden making antibodies to the joint space in the case of rheumatoid arthritis against DNA again, in the if it's lupus, right? um and no one ever talks about that. Why did it ever happen? And trying to stop it isn't all that easy. I mean, if you look at all the medicines that are out there, there's some pretty powerful medications that are definitely have an effect, but most of them don't cure your rheumatoid arthritis, and over time become sometimes less effective. So these hormones and neurotransmitters were labeled molecules of emotion by Candace Pert. For those of you who don't know Candace Pert, she passed away a few years ago. Was nominated for a Nobel Prize for her discovery of the endorphin receptor in the brain. So that, in fact, that was, I think, the first receptor that was actually isolated. She called those molecules of emotion. I love that term because that's really what these are. It's really emotions that cause the secretion of these hormones and neurotransmitters. But we don't talk about that. We don't think about it that way, right? And again, these things don't just happen. So think about, let me give you some examples. Embarrassment's a great example. So with embarrassment's a simple, I call it a simple emotion. It's not there 1 second, it's there the next second, right? It's not there, something happens, and then you get embarrassed. So you're standing in a group, right? Something happens and you get embarrassed and your face turns all red. You get that funny look on your face. Your whole body is exuding embarrassment. And you can't stop that as much as you would love to, right? So what happened there? So you had a thought, something happened. You had a thought, oh God, I can't believe that just happened. That caused the emotion of embarrassment. So it caused the secretion of hormones and neurotransmitters. In this case, the hormones that went to the face caused vasodilatation, right? So the blood vessels got bigger, more blood went to the face, and your face turned red. And you get that funny look at your face, and your whole body again exudes sort of embarrassment, right? So let's say you're going to bed one night and you get in bed, you're falling asleep, and you hear this noise downstairs. And your first thought is, "Ooh, I think someone broke into the house." So as soon as you hear that noise, right? Again, now you get afraid. You have the thought, "Someone broke into my house." You then start to have the emotion of fear and anxiety, right? So you secrete epinephrine, norepinephrine, dopamine, and such. Your blood vessels constrict. Your blood pressure goes up. Your heart rate increases because now you're ready to fight or flight or flee, right? Um, your palms are sweaty. Your pupils dilate, so you get more light into your eyes, so you can see better. All these things happen, right? So then you go, that was a sort of a funny noise. Let me go downstairs and see what's going on. And you get brave and you go downstairs and you see this broom maybe fell in your kitchen. And you go, oh, that was that noise. So now you go lay back down and you start to relax and your heart's still pounding, but it's starting to calm down, right? So your body reacted just as if someone had broken into your house, but yet no one was there. So it wasn't anything more than a thought that really caused the emotion of fear and anxiety. So we never think about it, but if you think and stop long enough, you'll come to see that from my perspective, all emotions are preceded by a thought. And you can change that perception, right? Why is that important? Because you can change that. What, I don't know what happened there. So we can go back to thoughts and to illness. Now you can, when I fill in the middle, it starts to make more sense, right? So Byron Katie tells a great little parable kind of story where if you're walking in the dark through the woods down a path and you look down and you see a snake, right? And so what happens? You get afraid, right? It's a snake. You might probably don't like snakes, but even if you don't mind them, you don't know if it's poisonous or not, right? It's dark. And so your heart starts pounding and your blood pressure's up and all the things we talked about, right? And let's just say you had a flashlight with you. And so you take the flashlight and you shine it on the snake to kind of see what it does. And when you do that, you look down and you go, wait a minute, that's not a snake. That's just an old rope that someone threw to the side here. Oh, right. So now you feel better, right? Your heart starts to calm down. You turn the light off, and the image you see is exactly the same as the image you saw before you turned the light on it. But now you're not afraid. Why? Because you know that that's just a piece of rope. And you can't be afraid even if you wanted to. So you see how, again, our thoughts are what lead to these emotions. And knowing what's true and what's not true can be very, very challenging, but it can also be very helpful. So We're going to talk a lot about, of course, I'm a physician, so I always relate this to the physical and, to illness and things like that. But this, it doesn't have to be. You can relate it to, just, mental health or just emotional kind of health as well. But from my perspective, you can really begin to see how emotions affect the body and the health of the body. So, we all know that when you get stressed, maybe you get neck pain, maybe you get headaches, right? Maybe you get belly pain. But what we really want to start to see is how these emotions can actually affect the body, the health of the body, and can actually make you sick. And it all starts with thoughts. That's the key. This is not something, again, this is a little kind of out there, right? This is not something we teach in medical school. It's not something we think about in our society. And so this has got to be learned or unlearn what was being taught before. So I'd like to talk about the event response sort of idea, so that there's an event, right? Something happens or some kind of circumstance, some kind of occurrence, right? And that event leads to a response. Okay. Now, sometimes this is instantaneous. It seems to be, right? But no matter how quick the response is, there's really a time interval, a gap, right? In that where before the response, after the event. Okay. And in this space really lies what I call the key to happiness. And this is where we're going to spend a ton of time in this workshop. Is we're going to spend time in this gap, because in this gap lies a choice. And what most of us don't realize is that choice is there every time with every event. The event is neutral. What causes the response is not the event, but your choice on how to perceive that event. The choice is conditioned, but it's not automatic. What's the choice? How it's not the event, but it's how it's not the journey, so to speak, either. It's really how you choose to perceive the event. And we're going to talk again a lot about that over the next several webinars. And of course, the corollary to that is that once you know that it's a choice, then you're in control. It's not the event that's in control, but you're in control. So I'll give you a great example of that. So um, I had a friend who's my PA. This is, I guess, 20 years ago. And him and his wife went out and adopted a baby from Romania. And the child was 2 years old. And so they brought him back, and he didn't speak English, and his wife took off 6 weeks from maternity leave to stay with the child, and then she was going to go back to work. So about 4 weeks into it, um, they decided that they would start slowly introducing him to the daycare that he was going to be going to. So they went together to the daycare this one morning, and they sat with him for a while, for about an hour, and just kind of played with everything. And then they were going to leave him for just about 5 or 10 minutes, just to let him start getting used to it, right? And so they left, or they went to leave, and as soon as they went to leave, the kid went nuts. He started screaming and yelling, and he was just a mess. And the mom, of course, panicked and said, "Okay, forget it. I'm just going to quit working, and I'll just stay at home, and I'll be a stay-at-home mom, and that's just the way it is. We're just going to have to live on your salary." And that's sort of understandable, right? It's a bad event, right? The child is visibly upset, very upset, and her response is, she's going to take care of the child and stay home. Seems like, there's not much choice there. My friend was elated. He told me he was ecstatic. And I said, "What?" And I said, "How could you be happy over that?" He said, "Oh, you don't understand." He said, "My biggest fear during that, when we were adopting this 2-year-old, was that he would never bond with us." And what I realized when he started screaming was that he had bonded with us, and I was so joyful. So he started to tell me the story, and I completely stopped listening because at that moment I said, wait a minute. And this was way before I sort of started this thinking in this kind of program. But I said, wait a minute, you know, um, if what just happened here was an event that to me seemed universally bad, right? I don't see how anyone would be joyful over this. And one person was miserable, and the other one was at peace or happy, let's call it. Same event. What was different? Just the perception, nothing more, right? So very important. That's a very important slide. And so that's what we're, again, keep this slide in mind because that's what we're going to be talking a lot about. So you see a lot of these things on the internet, right? Don't ruin a good today by thinking about a bad yesterday. Let it go. Well, if I could just let it go, I wouldn't have had to develop this program and gone through all of this. I never knew how to let it go. No one ever taught me how to let it go. There weren't any books that helped me to just let it go. What am I supposed to do? Open my hands and watch it just float away like a butterfly? That just didn't work for me. So what I came to understand was that transformation occurs only after you accept who you are without trying to change it. Now that doesn't mean that it may not change at some point, and that's very important to understand, right? but but the peace comes in accepting who you are now. It's kind of like the thing about, right, I'll be happy when, right, I'll be happy when I get the house, I'll be happy when I get the car, I'll be happy when I get married, I'll be happy when I find a mate, blah blah blah, right? um yet yet the truth is that really, you lose the weight and then you find other reasons to be unhappy. You get the car, and then you find, you're worrying about all the things about the car because it just got scratched and who knows what. And you find other reasons to be miserable. So the transformation occurs only after you accept who you are without trying to change it. That's the way I always looked at it. If you want to look at it the way Carl Rogers put it, he said, the curious paradox is that when I accept myself as I am, then I can change. He's a lot more eloquent than I am. And if you want the most eloquent, of course, is Rumi, right? So learn the alchemy true human beings know. The moment you accept what troubles you've been given, the door with open. If I write it like that, some people say that I misspelled something or used the wrong words. But so some years ago, this was given to me. A friend who I'd worked with had this painting done, and she said that this was the essence of my sort of teaching. That is finding acceptance as you are. Um, and so I took that and took a picture of it, and obviously I've got it hanging on my wall, but I've got it everywhere else. It's also the the background on my computer monitor, so that's a picture of my computer monitor. So I have that everywhere, because again, that's to me that is the key, really to peace. And the question is, how do you do that? How do you find acceptance as you are? And that's what we'll be spending, hopefully, a lot of time on. So that's the end of session one. Not too bad. So let me stop sharing this, and let's see. We can do uh, chat. We can either do questions. There's a place here somewhere where you hear your Q&A where you can ask questions, or you can put it in this chat if there are any questions. I think it scared away a bunch of people. And if there aren't any questions, I think what we're going to do next week, again, we'll still try to do um, Sunday and Tuesday. That seemed to work. I think it worked reasonably well. If anything comes up, you've got my email. You can always email me with any questions, comments, criticisms, concerns, what have you. um, and then, as I said, I will play this by ear. The webinar format is challenging for many reasons. This has worked well in the live sort of setting. It's worked well in one-on-one settings. I've been hesitant to venture into the webinar setting because it's challenging because there's not a lot of interaction. And I feel like I've been talking to myself here for the last hour plus. Um, and so we got to figure this out. Um, the more participation we can get, I think the better. How we're going to do that is again going to be challenging. We can open it up so everyone's mic is muted right now, but if people do get interested, then we can figure out a way to um, maybe have the discussion that everyone can hear. So, a couple questions. What did you realize was the case with that first woman on your last day of medical school? So, uh, it's a great question, um, and it's the thing. So one of the things that we realize um, inherently by, let's say, non-physicians, but even physicians understand it, right? If you're stressed, right, then it will likely affect your body in some way. So, and depending on where it is, we give it a different name, right? So if it's and this is true when you look at all the patients that we see in medicine, okay? And I don't care what the specialty is, it could be from primary care to specialist, it doesn't matter. I'll be generous and say that 20% of the time we find something and 80% of the time we don't. And it's probably even greater than that. It's probably more like maybe 5 or 10% of the time we find something. But let's just say 20% and 80 because that 20/80 is always good. Um, and so that large percentage of the time, 80% of the time, when people come in and they have headaches, we don't find brain tumors, right? If they're having chest pain, we don't find coronary disease. If they're having belly pain, we don't find cholecystitis or acute, appendicitis or Crohn's disease or ulcerative colitis. If they have back pain, we don't always find, herniated discs and things like that. And we have names for all these chronic physical conditions. These, let's call them chronic pain syndromes that um, that essentially says the patient's having symptoms, but we can't find anything physical going on. And so, depending on where part of the body it is, we call them migraine headaches or tension headaches or, chest pain syndrome or mitral valve prolapse syndrome. If it's in the belly, it's irritable bowel syndrome. If it's in the back, it's lumbago. If you're tired all the time, we call it chronic fatigue syndrome. If you ache all over, um, uh, fibromyalgia, right? So we've got all these, we call those diagnoses, right? They're really diagnoses of exclusion, but we call those diagnoses, and then we put you on medicine, right? But yet we also know that when people are stressed and they're um, susceptible to, say, irritable bowel or belly symptoms, when they're stressed, their irritable bowel will get worse. People who have migraines or tension headaches, when they're stressed, they have more headaches, right? But yet we don't acknowledge that to the degree that I think we should. And so in this particular woman who had, I mean, let's face it, her husband left her, her house burned down, and her dog died. And her dog died was the last thing, all within 3 months. Those all three of those in and of themselves are big events. And she had three of those events in 3 months. In fact, I think it was less than 3 months. Okay. So um all of that, I don't think of it as emotion. I don't like to think of it as stress because, again, stress is, it's hard to measure. It's kind of, it doesn't have a lot of meaning. But if you just think of those as very emotional issues, right? We know that when you get emotional, you might get nauseous, right? And so because there was that much going on, it seemed very evident to me that all of that emotion, was causing her all of these abdominal symptoms of, nausea and vomiting. We know that if you're under chronic stress, get ulcers and things like that, right? So we sort of understand it. Cardiologists do it all the time, right? For patients that come in with chest pain and they get evaluated, and we do all of our stuff and we find a normal coronary artery. And so then we kind of, pat them on the back and say it was probably just stress. And then we kind of push them out the door because we really don't know what to do with it. Go back and see your primary care doctor because, he'll know. And then he'll put you on anxiolytics and antidepressants and all those kind of things. And like I said, I don't necessarily have a problem with those. Certainly easy, but they're not fixing the root cause. And the root cause, what you're going to see, hopefully, the root cause is not the event. The root cause was not the fact that her husband left her and her dog died and her house burned down. The root cause was her perception of those events. Now, what's the problem with that? Well, the difficulty with that is that she now has to accept, if you're going to say my perception, then you have to accept responsibility for how you're perceiving those events. It's a lot easier to just blame your husband for leaving and, that blaming whatever the universe that your house burned down and that your dog died all at the same time. So then, but the problem is when you look at it that way, then it makes you a victim. And that victim mentality, you'll never hear me talk about right and wrong, good or bad, better, worse. I won't ever talk about that kind of stuff because choosing the victim role is fine if that's what you want to do. But the important thing isn't what you choose, it's the awareness that you made that choice. I'm choosing this. I'm choosing to be the victim. Fine, go ahead and do that. But also understand, be aware that in that choice, what lies in that choice. When you pick the victim path, and we're going to talk about this a ton, the victim path ends in misery every single time. 100% of the time. That's always where it leads to. And it's lined with all these negative emotions like anger and grief and sadness and misery. Okay. And so when you make that choice consciously, even though you know you made that choice, then what you find inherently is that as you're standing on that victim path, all of a sudden that path turns to the non-victim path, which always ends in peace. And that's, again, it takes practice, and we'll see, and I'll show you how you get there. But just a very different way of thinking, a completely different way of thinking. And so you have to be open to it. It's not for everyone. In fact, it's not for most people, because most people can't accept this idea that it's not the event, right? It's easier to be the victim. We support victims in our society, right? This bad thing happened to you, and we will support your victimhood. And again, nothing wrong with it, but it still ends in misery. So I hope that helps. I hope that makes sense. If it doesn't, email me. We can have this discussion. We continue the discussion. But again, this is the first session. Be open minded. This takes a while. It's a very different thought process. It's not the common thought process that we learn in our society. And so, but what goes along with it is key is this responsibility, self responsibility. And it's not blame. That's the other thing. We're going to differentiate it from blame. We're not talking about blaming yourself. That's another issue. That's another victim thing. That's another beating yourself up, self-criticism. We already saw the negative things that self-criticism does, how it, elevates your sympathetic nervous system and, and all that kind of stuff. Okay, so I've also recorded this. I will make this available. I'm trying to develop the website where it'll be a membership site and you can get it off the membership site. I haven't gotten there yet. If you specifically want the recording until I can get it and set up on the website, email me and I will get it to you somehow. I'll Dropbox it to you or something like that. in the meantime. If you want the slides separately, I can give them to you also as a PDF. If there are no more questions, then we'll sign off, and I will see you next Sunday or Tuesday. And again, I think we'll keep the Sunday and Tuesday thing. That's where the survey was kind of helpful. About 75% answered on Sunday. We had about, I think we had about 35 or 38 people sign up, and I think about 32 showed up. We had about 20 sign up for tonight. So pretty good turnout. We I think had 125 total, so that's actually pretty good turnout for a free webinar. Normally, about 15% of the people show up. So, well, thanks everyone. I appreciate your listening in, and please email me if anything comes up. Thank you.